Good afternoon, everyone, and continue to put in your states in the chat box as I'm starting off our introduction for today's series. So welcome to our ASTO Connects webinar on innovative applications of Geographic Information Systems, GIS, for population health. This will be a 60-minute virtual session sponsored by the Association of State and Territorial Health Officials, or ASTO. My name is Priyanka Suryo, and I'm joined today by my colleagues Nick Porter and Sanya Fatak. I'm the Director for Data Analytics and Public Health Informatics at ASTO. We're also glad to have Sanya working with our team as part of our arrangement with George Washington University, where she's completing her practicum experience for her Master of Public Health degree. I'll be co-moderating today's webinar with Nick Porter, ASTO's Senior Analyst for Environmental Health. So just as a housekeeping item, we are going to set aside time at the end of the presentation for questions and discussion. Feel free to enter a question into the chat box at any time if you are afraid you'll forget it, and we'll respond to them at the end. Also, at the end of the program, we'll be taking questions via phone. So if you want to pipe up, unmute yourself and pipe up with any questions you have. This is an interactive event, so your participation is important to the success of the webinar, and we'll also have a couple polling questions. So before we get to the presentations, we would like to provide some background context on ASTO's work in the area of GIS and population health, which is what brought us here today. So I'll start. ASTO has explored current GIS capacity of state and territorial health agencies through developing and disseminating a survey to our state environmental health directors. We also explored the landscape of innovative applications of GIS for population health and public health purposes through systematic literature review, market research, and analysis over the past year. And I'll turn it over now to Sanya, who will speak to some of our high-level findings, which you also see on the slide in front of you. Sanya?
Hi. So our systematic literature review spanned nearly 50 sources from academia, research institute, and news outlets and medical centers. 12 sources explored the topic of GIS integration with electronic health records, and 3 of those sources, which included a hospital, university, and the US Army, were actively pilot testing or implementing GIS integration into an EHR. 38 state and territorial agencies answered survey questions on their capacity of environmental health surveillance and GIS, as well as their readiness for using GIS to map EHR data. As you can see, most agencies are using desktop and web GIS, and more specifically, ArcGIS for location-based mapping. Most agencies are in the planning or operations and maintenance phase of the systems development lifecycle for using GIS to map EHR data. And now I'd like to hand it over to Nick Porter to introduce today's speakers.
So before we begin, we're actually going to start with a polling question. So if we could have our Vic open that up. And if you all could take a couple of seconds to please answer, how comfortable are you using GIS for public health decision making? And we'll close that in about 30 more seconds. Great. So it looks like based on the results of those who answered, we've got a majority who are somewhat comfortable and then followed by somewhat uncomfortable. So hopefully by the end of this webinar, you'll learn a couple more new things about GIS and how they can be used. Thank you so much. So Nick?
Great. Thank you so much, Priyanka. Welcome, everyone. My name is Nick Porter, and I'm a senior analyst here for the environmental health team here at ASTO. And so listed here on your screen, you'll see today's speakers. We have Dr. Estella Garrity from Esri. and Dr. Mark Warner and Ms. Erica Garcia-Lago from the Wisconsin Division of Public Health at the Wisconsin Department of Health Services. And so now I would like to introduce formally our first speaker, Dr. Estella Garrity. So Dr. Garrity is the Chief Medical Officer at Esri, a developer of the world's most powerful mapping and analytics platform. As the leader of Esri's worldwide health and human services practice, she is passionate about delivering value through a geographic approach. Formerly a Deputy Director with the California Department of Public Health, she led the state's Open Data Initiative. She also served as Associate Professor at the University of California, Davis, conducting research on geographic approaches to health policy and community development. In addition to degrees in medicine, medical informatics, and public health, Dr. Garrity is also a Geographic Information Systems professional. Dr. Garrity, are you there?
Yes, I am. And
all right, go ahead and take it away.
How's the picture? That coming through?
Oh, yeah.
Yes.
Great. Okay, so hello everyone. It's really a pleasure to address you today to talk about how Geographic Information Systems, or GIS, can be used for population health, particularly from the perspective of its integration with electronic health record data. So let's go ahead and get started. Next slide, please. I thought it might be useful to begin by ensuring that we're all on the same page about what a GIS system is. So at Esri, we call our work the science of where, and that science begins with answering fundamental questions of where, like where's the problem, where is it changing, and where should we locate a resource? So if we take this to the next level, I think we can see in the next slide, thank you, that a modern GIS system, it expands on those questions of where with a complete framework and a process for applying geographic knowledge really throughout health workflows. So it goes beyond visualization and includes tools to help with data collection, data integration, and data management. There are about 1,000 analysis tools help data scientists and epidemiologists to understand root causes of what's going on. Organizations can prioritize and design interventions, collaborate with their stakeholders, take action, and evaluate their outcomes. Now, since everything happens somewhere, a GIS platform brings meaning to that location information. And so with that brief introduction to GIS, let's now take a look at the state of population health today. You know, if you're like me, perhaps you've always thought that the purview of healthcare was kind of in the microscopic aspects of disease, and the sphere of public health has been the broader, more telescopic view of populations and health context for people. But nowadays, things are changing. Next. I think we can finally say that the cat's out of the bag, and there is a clear recognition, I think, across all health professions that population health and that perspective is really critical to any path forward in health transformation. Next. So as one point of evidence, I'll cite this. Electronic health record vendors like Epic, Cerner, Athena Health, and eClinicalWorks are all making moves to expand their EHRs to CHRs, or comprehensive health records. According to Judy Faulkner, the CEO of Epic, they're planning to integrate all kinds of new data types that will provide a more complete picture of the neighborhood and the community factors that impact an individual's health. Looking forward, I think that this is a big deal. Next slide, please. And I think it represents a kind of convergence that brings together components of public health and healthcare. This, in my opinion, is a really good thing, and I think it offers an opportunity for greater collaboration and coordination between public health and healthcare. And of course, I think GIS is a technology that readily can support this emerging pattern. So let me turn to my agenda for the next few minutes. I'd like to share some examples, next slide please, of how EHR and GIS integration is actually happening and the benefits to the public health mission. So my examples are going to cover the areas of better surveillance, better resource allocation, and better security, all with an eye toward making better decisions for better health. So let's begin with the topic of surveillance. We've seen mapping used to make better decisions during flu season. This was highlighted last year on NBC News when a hospital tracked positive flu cases over time, which helped them to plan for surge conditions. In the next slide, you can see that they ultimately used this data-driven evidence that they gathered to determine when it was time to set up a tent to increase their ER capacity for flu patients. Next. At the same time, Walgreens is also doing flu surveillance. They created a flu index that uses prescriptions for antiviral medications like Tamiflu to assign a likely flu case. And Walgreens is actually able to spot trends within a few days as opposed to the CDC's 2-week lag time for reporting on flu. Now, when hospitals and pharmacies share this type of time-sensitive data with public health, medical countermeasures such as vaccines can be activated even sooner. So let me turn to an example of what public health can do when they have good information about the spread of flu or any other vaccine-preventable disease outbreak. Now, while this may be an extreme example, let's say that they would deploy pods or point of dispensing sites in the local area to distribute vaccines. But where should the pods go? Let's consider the city of Mobile, Alabama. So in this case, using a GIS territory design tool, it was possible to create a number of specific territories based on population numbers. So I'll go through the math. The city of Mobile has a population of 190,265 people, and a pod has a capacity to serve 20,000 people. So if we wanted to include the entire city, we would need 10 well-balanced territories for our pods. In the next step, we'll want to find the best location to place the pod within each territory. In this case, we're going to focus on schools since they tend to be good community venues for this type of a need. So here, what you're seeing in Territory 8, we wanted to find the larger schools. So we used the number of employees as a proxy to measure school size. So the 3 markers that you're seeing show the schools that had more than 100 employees. So these are going to make good candidates for our pod locations. Now, if we look at the next slide, we continue the analysis by creating a walking time buffer around each school, and then we pulled in data for the population that's contained within that buffered area to help us select our best site for the pod. So we want to find an area that has low traffic counts, lower population density, so that people don't run into a lot of traffic when they're trying to reach the pod. We also wanted to increase access for people age 65 and older, and for those who don't have vehicle ownership. So using all of these criteria, we can determine that the best site is the darkest colored school that you see on the map, which is John L. LaFleur High School. Next slide, please. So this is just one example. When we think spatially and we get great surveillance data, we can do lots of things, like mapping varying vaccination policies to identify where religious, personal belief, or medical exemptions are allowed. We can calculate gaps in vaccination access, whether those gaps are related to geographic access or financial barriers. We may wish to identify high-risk and under-vaccinated populations to strategically target our efforts. And we can create mobile or web applications that show people where they can find local resources. If we're looking to overall public health goals, we might want to develop map-enabled dashboards that show things like which communities are achieving the Healthy People 2020 goal of 95% MMR vaccination. And we can coordinate closely with our healthcare professionals by equipping providers who are working in areas that have low vaccination rates with educational materials, maybe those that are specific to the anti-vaccination population, to help them communicate as effectively as possible. So next, I'd like to look at better resource allocation. So in the next slide, Children's National Hospital in Washington, D.C. did a study on readmissions for kids who have sickle cell disease. Now, they found that there was a statistically significant effect of geography. So for kids who lived more than 5 miles away from the hospital, they were more likely to be readmitted. They determined that the reason for this was because those kids didn't have the same level of access to appropriate subspecialty medical care. So in their GIS and EHR integration, Children's National developed an alert, and that alert was triggered when a sickle cell patient who lived further away was then admitted to the hospital. And so the alert would indicate that this particular patient is at a high risk for readmission. So I think when public health understands the resourcing issues that are facing a community, they have the capacity and the know-how to address those kinds of community needs. Next. Loma Linda University Hospital used community resource data to bridge the gap between healthcare delivery systems and the patient's home and community. So they created what you're seeing here. It's called the Wellness Map, and it's a personalized tool that can be accessed through the patient's portal in the Epic EHR system. So the tool has 3 main categories of resources. In blue, you're seeing the patient appointments, their primary care provider, and their preferred lab and pharmacy information, and all of this comes directly from the EHR system. The green section is for health and wellness categories, and the orange section is for social supports. So both the green and the orange sections show only the resources that are relevant to that patient based on their diagnostic codes. So if the EHR says that the patient has diabetes, then they're only going to see diabetes resources on the map. I call that personalized medicine. Next, we can see that patients can get relevant information about each resource. Even they can receive multimodal transportation directions to get to that resource. So the whole idea here is to encourage utilization of appropriate resources to obtain better health outcomes. Okay, so moving on. I don't have a great deal of time to go deep into HIPAA and protected health information, but I did want to say just a few words about the topic. As you know, when you combine health information with personal identifiers, you end up with protected health information, and you need to take precautions to maintain individual privacy. Obviously, an address or a location is a very common type of personal identifier. Now, over the last few years, our team's been working really hard to help folks who are interested in GIS to navigate HIPAA with regard to geographic science. So I think it's important to recognize that all of the flexibility in the privacy law comes from the expert determination route to de-identification. And there are several techniques that can be used. Some are simply cartographic methods that aggregate or they blur the data in different ways, and other methods actually move data points in a way that still preserves patterns, but it protects individual privacy. Furthermore, we also have tools for HIPAA-compliant geocoding. And by the way, geocoding is absolutely foundational as a capability for using GIS at all. So what we're trying to do is reduce barriers to analyzing high-quality, individual-level data. And finally, I wanted to provide you with some relevant resources that are related to my comments today. So you can take a look and see the current Walgreens Flu Index. You can learn more about immunizations and mapping, and check our website also for tons of ideas about applying GIS across the public health spectrum. You might also want to investigate our public policy mapping site. It's a great place to explore your own community and see what's going on. And finally, I just want to leave you with my email because I'd be really happy to talk to anybody about their GIS needs or challenges. So thank you very much for the opportunity to chat.
Thank you so much, Dr. Garrity, for that great presentation. Great. All right. Well, moving on, I'd like to formally introduce our second speaker for today's webinar. Dr. Mark Warner is the director of the Wisconsin Bureau of Environmental and Occupational Health. In this role, he provides senior leadership on a range of programs, including lead and asbestos surveillance and certification, monitoring and inspection of radiation sources, chemical hazard and radiological emergency response, climate and health, asthma control, and environmental epidemiology and public health surveillance. He's worked at the State Health Department since 1997 and received his doctoral degree in environmental health from the University of Minnesota and completed a postdoctoral fellowship in occupational respiratory disease epidemiology at the National Institute for Occupational Safety and Health's Division of Respiratory Disease Studies. He holds adjunct faculty appointments at the University of Wisconsin-Madison's School of Medicine and Public Health and the University of Wisconsin-Milwaukee's Zilber School of Public Health. Dr. Warner, are you there?
I'm here.
All right, go ahead and take it away.
Okay, thank you. So what I'm going to talk about today is essentially why geocoded hospitalization data are good for your health, and partially making the environmental public health case that led in part to us getting geocoded hospitalization data a couple of years ago. So on the next slide, I'll describe some of the objectives of my part of the presentation, which are to describe the benefits and concerns associated with geocoded hospitalization data and to characterize the environmental public health benefits of those data. So as in a lot of states, we have hospitalization and emergency department discharge data that are largely administrative data. Formerly, they were collected and compiled by our agency, but about 15 years ago, the collection and compilation of those data moved to the Wisconsin Hospital Association. And we have an agreement with the Hospital Association, so those data are made available to our agency for public health surveillance purposes. And based on state statute, for many years, the geographical level at which those data were presented was down to zip code levels. We'd have county level, we have county as well as zip code as the most geographically specific parameter in the database. So on the next slide, if we look at some of the difference between various population measures that could be used for hospitalization data or other sorts of data, when we're collecting data at the zip code level, if you look at the number of zip codes in the U.S., there are about 42,000, and they range in size from a population of 1 to a population of about 115,000. In Wisconsin, I think that range goes from about 15 at the low end to about 45,000 at the high end. But if we go down to a more a lower level of geographic specificity, such as the census tract, there are about 65,000 of those in the U.S., and the population size ranges from 2,500 to 8,000. So we're getting closer to more of a neighborhood level, where if we were to use that as a basis for, if we had that level of specificity, there are certain improvements in terms of our ability to localize health issues in communities. Going down further to the census block group, about 210,000 of those in the U.S., with an average population size from 600 to 3,000, and all the way down to the census block, where there are about 11 million, and the population ranges from about 0 to 300. So there are some other options that are available to us if we are able to move to a lower level of geographic specificity. So on our next slide, if we think about zip code level data and think about it a little bit more. So based on the preceding discussion of population measures, it's clear that some zip codes can contain a large population and cover a large area. For example, this particular, the zip code that's displayed here is the zip code in which I reside, which is 53704. And this map depicts the area corresponding to that zip code, which covers about 22 square miles and contains a population of about 44,000 residents. So if you think about the various environmental health hazards that one might want to evaluate as contributors to hospitalizations or ER visits, you can see that in this case, the zip code classification does not provide great resolution and may not be terribly useful. So on the next slide, if we zoom in a little bit into the zip code a little bit more, and we think about a particular relationship that we might want to consider in the environmental health realm with respect to our hospitalization and emergency department visit data, one question to consider might be if there is a relationship between freeway-related air pollutants and, let's say, asthma-related emergency department visits. So if we look at this slide, we can see that in that the distance between some residents of this zip code and the freeway, in this case, is roughly next door to the freeway. And on the next slide, if we look over at this part of the zip code and the Maple Bluff area, we're talking about a neighborhood that's about 3 or 4 miles away from the freeway. And so we can see that there can be a great difference in terms of exposure and some concern about exposure misclassification if we're using zip code level data to explore certain environmental health questions. So while there can be other measures of exposure that could be developed to inform this particular question, we felt that the question of freeway-related air pollutants and asthma ED visits was a solid one upon which we could help construct a case for creating geocoded hospitalization data in Wisconsin that would give us better resolution than the zip code level, and consequently could improve environmental public health surveillance in the state. So in Wisconsin, the historical use of zip code as the most specific geographical level at which data could be collected is codified in statute, which meant that if we were going to, in order to get higher resolution data, we needed to build support in the legislature as well as the governor's office. So on our next slide, luckily there was support from the Wisconsin Hospital Association, which, as I mentioned earlier, compiles these data from its member hospitals. They also saw value in having geocoded hospitalization data to provide measures such as the fraction of patients in a particular neighborhood that seek care at specific area hospitals, and those data would be useful for them for marketing and outreach purposes. Next slide. So with the support of the hospital, with the Hospital Association, and with us helping to construct a public health business case based on our ability to articulate the public health utility of geocoded hospitalization data to look at issues such as freeway-related pollution and asthma-related health outcomes, legislative champions were able to be identified, and legislation allowing the Wisconsin Hospital Association to temporarily record patient address for geocoding down to the census block level was passed and signed by the governor. Next slide. So these geocoded data have been collected since 2018, and we anticipate that they will provide valuable insight into the geographic distribution of conditions and health outcomes such as asthma, for which hospitalizations and ED visits provide a really important surveillance endpoint. In addition, we think these data, once we have enough years for us to start analyzing them in a robust way, we think these data will help us answer important questions related to health equity, where understanding the variation in health status and related exposures by neighborhood can be of tremendous value. So with that, this is my contact information. Obviously, we're holding off on questions until after all the speakers, but this is how you can get a hold of me if you have specific questions later, and I'll be around at the end of the presentation too to answer questions.
Thank you so much, Dr. Warner. I really appreciate that. Great. Well, moving on then, we will move to today's third and final speaker, Ms. Erica Garcia-Lago. So in her current role as an integrated data analyst for the state of Wisconsin in the Department of Health Services, Division of Public Health, Office of Health Informatics, Ms. Garcia-Lago serves as the data steward for the hospital discharge data. She handles ad hoc data analysis requests as well as management of the state's hospital data. She has a master's in medical sciences from Boston University and a bachelor's in mathematics from Hamilton College. Ms. Garcia-Lago also did coursework in biostatistics at the Harvard School of Public Health, and she has 1 pediatrics and 2 JAMA publications on clinical endocrinology and nutrition research. She also co-authored the 2016 and 2017 birth reports and the 2017 abortion report for the state of Wisconsin. Ms. Garcia-Lago, are you there?
Yes, I am. I do have to apologize, though. I just got kicked off the Zoom webinar, but I have my notes in front of me, and I will do my best to follow along with the slides.
Sounds good.
Okay. Okay, thank you. So yes, I'll be talking about how the Wisconsin hospital discharge data is geocoded, some of the technical aspects. And in this next or first slide, I'll mention that this past year, 2018, was the first year that block group was provided in the hospital discharge data. Block group is the finest granularity allowed by Wisconsin Statute 153. And in the next slide, I'll talk a little about how we get the block group. Geocoding is done using up to 2 programs here in Wisconsin. If the first program, which is called PostGIS, is unable to deliver acceptable accuracy, then a second program is used that's called ArcGIS. In the next slides, I'll talk specifically about these programs. PostGIS is used for the first round of geocoding. It's a free open source software. And given that it is open source, we did do some preliminary research to compare it to paid services like Google, Microsoft, and MapQuest. We found that 98.5% of the records match the results that we got with Google and Microsoft, and that that is among the addresses that we were able to geocode. PostGIS delivers block group based on street level information. It can be set to deliver based on rooftop, which would increase specificity, but that might decrease the number of records that get geocoded, so the decision was made to stick with street level. PostGIS uses its own rating system to tell us how accurately it provides that block group. If the score is less than 5, then accuracy is high enough to trust the block group delivered by PostGIS. If the score is greater than or equal to 5, then a second program is used that I'll talk about in the next slide. So that second program is ArcGIS. It's used when PostGIS is unable to produce an accurate block group. This is not open source software, but it does provide up to 1 million free geocodes per month. ArcGIS delivers the latitude and longitude based on street level. That information is then fed back to PostGIS to get the block group. There are no accuracy issues with that transformation from latitude and longitude to block group. However, there is a separate accuracy rating system from ArcGIS for getting the latitude and longitude. And a score of 85 is a score greater than 85 is a good score for ArcGIS. And in the next slide, I'll talk about records that we simply aren't able to geocode. So using the methods that we've discussed, 97.3% of the records have an associated block group. And only a small number of addresses don't get geocoded. For example, PO box addresses don't get geocoded. We're also unable to geocode records for patients that are homeless or that don't provide an address. And only Wisconsin and border state addresses are geocoded in our hospital data. In our next slide, I'll talk about what our future plans are for the data. The Wisconsin Hospital Association has agreed to look into creating 3 new fields for us. We'll get the accuracy scores from PostGIS, accuracy scores from ArcGIS if that's applicable. And we'll also know the reason for a missing block group. So we'll know if it was because someone was homeless or we simply got a PO box or there's no address. And in addition to these, the state of Wisconsin Office of Health Informatics is working on adding a 4th variable that will provide block group only when accuracy scores are in that acceptable range. We're hoping that this will help epidemiologists that don't necessarily need to know all the details of the accuracy scores. They might simply need to know if the block group is trustworthy. These additional variables will only be provided for future data going forward, and we won't be able to provide that for past data. And that concludes my talk on some of these technical aspects of our geocoding in Wisconsin. And if you have any questions, please feel free to email me. Thank you.
All right. Yes, thank you so much to all of our speakers, Dr. Garrity, Dr. Warner, and Ms. Garcia-Lago for your illuminating presentations. And I'm sure that we'll have some questions. But before we get to that, I'd like for everyone to get ready and answer our second polling question of the day. And you'll have about 45 seconds to answer this one. Great. So I'm going to go through the results, and then I'd actually like to give an opportunity for our speakers to kind of talk through a little bit about those barriers. But it looks like, as it relates to your organization's biggest barriers to using GIS, half of you on today's call said that you don't have staff with GIS knowledge. So that might speak to those of you who said that you didn't feel as comfortable using GIS. And then followed closely by there's no budget for these tools. And then again with data security. So actually, for those that said none of the above, if you could enter your answers in the chat box, that will also help us kind of talk through that. But I'd like to give an opportunity for our speakers to kind of talk through these barriers and what your thoughts are about them and about how to navigate through them.
Thanks. This is Esty. I'll start if that's okay.
Yeah.
So I'm not at all surprised to see that the top answer is that we don't have staff with GIS knowledge, or maybe a few staff and not enough to really take advantage of geographic information. That is common across health. I hear it in healthcare. I hear it in the pharmaceutical industry, payers, and public health and social services. So I'm not surprised. I guess what I would say is a couple things. One, since 87% of you are using Esri software, all of our training online is free. Unless you want somebody to come to your organization and do in-person training, there are literally thousands of hours of free training online, and we'd be happy to help guide which training courses might be best for the needs that you have, which goes to the second point I was going to make, which is you don't have to learn everything. You just have to learn the thing relevant to the question you're trying to answer, because I know the platform can be a little intimidating. There's a lot of tools there. So that's how I would comment on that one. The data security I mentioned, we're doing a lot of things. I'd be happy to answer questions about that. I usually do an hour-and-a-half long talk instead of one slide. So we have some materials that talk about architecture that helps with the security rule for HIPAA, and then we have methods to deal with the privacy rule of HIPAA, and I'd be happy to share all of that with you. As for budget, I think I should address that one as well. We'd be happy to help people figure out what solutions will actually meet their budget. There's actually a lot of things that you can do for free. I would recommend, if you have at least one license, you can look online to the ArcGIS solution templates. And there's about 250 or more templates for things like resource locators or Survey 123 to do the homeless point in time count. And you can download them and use them immediately at no cost. So lots of ways to get value without spending more money.
Yeah, and Mark or Erica, do you have any other thoughts from the health agency side on how you've been able to navigate some of those barriers or leverage GIS and geocoding?
Sure, I'll offer my perspective. So I think we do have staff with GIS. We have staff with GIS, some staff with GIS knowledge, and we have our GIS guys, the Division of Public Health, who who do really great work, but there aren't enough of them. And so sometimes it's a matter of getting a particular GIS project onto their list or being able to prioritize it and getting it done in a time frame that's useful, just because we have so much work for them to do and only a few of them. I think in terms of internal policies and data security, I think we felt like on the hospitalization data side, we had to to some extent, we had to wait for the right time to have this conversation that got us to where we ended up. I was personally involved with the Environmental Public Health Tracking Program at CDC for about 10 or 15 years, and was on the hospitalization content development group for a number of years. And we had folks from the National Association of Health Data Organizations, sort of the national organization for state hospitalization data systems, and they were letting us know that some states were moving in a direction where data with better resolution were available, and sort of encouraged us to start having conversations internally or showing products from other states to the folks in our state, both the hospital association and to our internal leadership, letting them know that if and when they were ready to move in that direction, that there were some real benefits. And so I think having some of those resources and getting to a point where both the hospitalization and the state health department felt like there was something in it for both of us to try to get some policy changes that might allow us to get better quality data. I think having a good sense as to when that time was right was really helpful for us.
Great. Anything else, Erica?
We have recently started a hospital user group to like the new geographical.
You're breaking a little bit.
Oh, is this all right? Hello?
Yep.
Hello.
That sounds a little better.
Yep.
Okay, great. So we recently started a hospital data user group to discuss issues like this new block group data that's coming in. We only recently just got the full 2018 data set, so it's right now that we're starting to explore it. So we've gotten epidemiologists together into one room to discuss issues that they're finding, do some cross-training. We also have this new data sources center initiative where we're going to start creating trainings to introduce block group using the GIS block group in analysis.
Thank you for that. Now I do want to address a couple of the comments that I've been seeing. So I do see in some cases where there might be not enough staff. So you have staff in one department or one part of the agency who have the knowledge, but then they're stretched thin given resources, or the number of licenses is reduced or limited. And so if any of our speakers can speak to that, you know, anything about varying staff within different departments or agencies and how you better coordinate that work.
This is Esty. I've seen a number of different ways that folks are trying to collaborate, and I think that collaboration actually makes particularly good sense in today's world where we have complex problems that require multiple programs or even multiple organizations. So one thing I would say is I've seen some people centralize location services, and then that becomes a center where they pull in the requests and do work for others. That's more practical in an organization that has pretty strong expertise with maybe 3 people or more. But others, I think if you can find the win-wins in a cross-department or cross-organization sharing capacity. For example, Vital Records in California often worked with the WIC program, and we did some GIS projects together that benefited both programs. So that's a way to share some capacity, but I think a lot of those have to be based on a mutual project interest. But again, I think in today's world, that's not too hard to find.
And then the last question that I'm going to ask related to this, and then I'll open it up to the group for other questions, or we'll kind of look through the chat to ask those. But there were a couple of comments around, what if I happen to be in a state or an area that's very rural that has very limited population numbers, and how to address the privacy or data suppression around that. So open to any of our speakers to answer.
So this is Esty. I'm happy to take a stab at this one. This happens frequently, and we we care about all of our more rural counties, cities, and states with low population, and I know it can be a challenge. What I would say is that there are some data sets that can be available at smaller levels. For example, Esri provides 15,000 different data variables at the block group level, which can be a real benefit to get started. The other thing that I'll mention is that now with some artificial intelligence tools, you can predict down. So it's a calculation, it's not perfect, but if you don't have data and you want to get data, you can at least see the potential prediction and know your error calculations. So I'll just mention one of the tools we have available. It's called forest-based prediction. So it's a machine learning algorithm that uses multiple variables to predict data down. And we used this to validate with the 500 Cities project that the CDC has worked on. And they pulled data from the BRFIS data set and did it at a more granular level for 500 cities. We did it for the entire country and got great accuracy. So you can predict down, and now with today's technology, it's a little easier.
Great, thank you for that. All right, so I would like to open it up now to the audience to ask any questions. And again, you can enter your questions into the chat box, or just unmute yourself and ask by phone, since there has been a lot of discussion in the chat box, which is great. So I'll go ahead and open it up to the audience for questions, and we'll also look for questions in the chat box.
And just a quick note about unmuting yourself, it should be *6 if you're dialed in.
Hi, this is Laura Lamprecht. I was wondering if there was a plan to make all GIS and mapping tools interoperable regardless of the tool. So for example, like Google Maps or GIS or something else.
Sorry, I was muted. I'm happy to take that question, and actually I thought that might come up. So Nick, if you can show that slide that I had in reserve. Thank you.
Should be up.
Yep, I see it now. And so I can't speak for Google or other platforms, but I can say that that's the direction that we have been going and we are going. So, there was mention of open source. Esri, of course, is not open source software, but we are an open platform. And so I want to explain what that means. So our software is engineered to be open and interoperable, and we do it in 3 specific ways. First, by supporting all of the leading open standards and formats. Second, by engineering direct connections between our platform and many other platforms like the Adobe Cloud or Autodesk and dozens of others. And then third, we designed into the core platform an open architecture. So it's open data, open APIs, open source components, integration with other open source tools, like we have an R-Bridge, Python toolbox, and an open architecture that can be extended easily by developers. And we have an entire developer website, and you can do a lot on the developer website absolutely for free. So we found this to be a successful strategy, and we think other organizations may be going this way as well, but I can't speak to them.
Great. Any of our other speakers want to answer that? If not, I'll go to the next question. Okay. So is there a National Hospital Data Work Group or something analogous to that?
This is Esty. I'm not aware.
Okay, well, that sounds like a question that maybe we could take back for our own research. So thank you, Ned, so much for asking that. And if we can get an answer for you, we will share it with the group. The next question that I'm seeing here, is anyone aware of case studies using geospatial analysis related to drinking water contaminants or drinking waterborne pathogens?
This is Esty, and yes, I'm aware of several. A lot of work, of course, done in Flint, Michigan. Also, state of Washington has done some really great things with using mobile tools and dashboarding to inspect water fountains and all water resources in schools. This was also lead oriented, so not as much drinking water pathogens. I also know of other contaminants like assessment of wells for arsenic. So I'd be happy to share some of those if somebody wanted to email me, and I'll pull them out for you.
Yeah, this is Mark. One of the platforms that we've contributed to in terms of development is, and it's a pretty good example, the private well water viewer that's run out of the University of Wisconsin-Stevens Point. So if you Google something along those lines about the private well water viewer and UW-Stevens Point, you can probably find it pretty easily. And that has a lot of publicly accessible data that are available on well water contaminants. I think there are about 20 or so parameters, and they can go down to the township and section level. So I don't think they go any lower than that. But I think it's a good, if you're looking to design that sort of a tool, I think it's a good example to see what sort of information you can find. And we've done a lot of work trying to get our local county health department labs to contribute their data to that viewer so that their residents have their experience reflected in that database.
Great, thank you so much, Mark. Another question that we're getting is there a way for public health to send geocoded data back to electronic health records for patient care, specifically related to social determinants of health?
So at least in Wisconsin, the Wisconsin Hospital Association does the geocoding, and
I think you might be on mute. Oh, go ahead. Could you start over with that?
Oh, sure. This is Erica. At least in Wisconsin, the Wisconsin Hospital Association does the geocoding after they receive data from the hospitals. Then the hospitals do have access to that geocoded data.
Great, thank you for that. Anyone else have insights on that?
So I think the technology part is easy, and the way that public health gets a lot of data is now through the health information exchanges with hospitals, and those exchanges were meant to be bidirectional. So, so technologically, it's possible. Again, I would go to the use case and the need, and it would build a lot of collateral in terms of providing value for hospitals and getting them to provide more data for public health.
Okay, great. Are there other questions? I'm not seeing any in the chat right now, though I'm looking. But other questions, feel free to pipe up and ask those.
Hey, this is Ned with Northern Kentucky Health Department. Will you guys have a recorded presentation on this?
Absolutely.
Yeah, we will. Yeah, this is being recorded, and we will be posting it on our website as well. Some more details on that to come along with the slides. I know I saw that early in the chat box. Other questions? Thank you so much, everyone, for sharing your examples, by the way. I'm seeing a lot of activity in the chat, so definitely encourage folks to resource that and take advantage of the links and the different sharing that's been going on today. And in fact, if you actually go to your chat box and you hit the More tab, you can actually save the chat if you want to be able to save some of these links and resources. We'll also be compiling them as well as part of our work here at ASTO to include in our larger kind of final report or presentation. So all of that will be collected. Any other final questions before we wrap up? All right, well, thank you all so much for a great verbal and chat discussion. I'd like to now hand it back to Nick to close us out for today's webinar.
Yeah, thank you so much, Priyanka. And again, I just really wanted to express my gratitude to the speakers and for everyone who presented or everyone who participated by asking questions and posting resources during today's webinar. We really appreciate that, and thank you very much. So again, thank you for participating in today's webinar. Please note that we will be sending a brief evaluation survey to those who registered for the webinar. And you can see that the URL for that evaluation survey here on your screen on this slide. It's bit.ly/GIS-POP-Health. So please do take it's a real quick 2 to 3 minute survey. Please take a moment to go there and provide your feedback for today's webinar. It really does help us when designing future webinars, and we really appreciate you taking the time to do that. Otherwise, I again thank you everyone for being on the webinar today. That concludes today's meeting. Thank you and have a wonderful day. You may now disconnect.